sluggish there. All right, pick it up. It's great to be with you here again, Del, for your benefit. Each month we've been doing a little module in these meetings, focusing on leadership's role in supporting all of this work. And as Wendy said, all of the evidence base and leadership around change, quality improvement, really points to leadership as being a critical success factor or a critical failure factor when things don't go well. We talked about team-based care. There's a lot of energy going on in that team-based care land right now. We've got over 120 some people participating. That's a lot of folks. A good example of leadership's role in supporting that, often you'll sign someone up, a team to go, and then that's the last they hear from you to the end and say, oh, how'd that thing go? And it's clearly a sign that this is just kind of another thing we're doing or checking off the box, as opposed to checking in regularly with each of the team or the team members. What are you learning from the process? How's this translating into improvement? What insights are you gaining? Also be forewarned, by opening Pandora's box about team, it starts to surface a lot of the culture issues in the organization and some of the challenges and some of the silos we often support in our own organizations. So they're likely to start to get into some dialogue around that, and that's part of our role in leadership, is to help navigate that, help them navigate, and also learn from it, learn how we can break down some of those barriers and silos. All of the work that's going on now is really supporting the culture pieces and moving towards how do we start to really do team-based care, not just be a team, but team-based care, where we're taking the work and really spreading it across the team and really managing to the top of our licensure. I remember working in Iowa on an improvement effort for one of the payers. And we had an organization with an early adopter physician who'd been physician of the year, many of the year in the state, really high performer, great guy. And he sat down in this group that we're meeting and said, oh, we've got a great team. We've been working like a team for years. And I saw his two team members roll their eyes, behind him. And he goes, right, ladies? And I'm like, oh, yeah, sure. And I stopped. I said, look, can we talk a little bit about, just notice a little body language with, well, Dr. Jim, we've worked together for 25 years. Yeah, we've been great. We're not really a team. And he just tells us what to do, and we just do it. There wasn't a real sense of team. It was a sense of loyalty around the physician or provider, not working as a team. And what we're suggesting in this new world, there's so much work to be done. It can't be all on the shoulders of one individual. It can't be the lead clinician in the organization. We have to take that work and spread it across. But to do that, you have to have the trust and the ability to really feel that sense of trust. And so that's what we have to try to help build in the organization. So today I'm going to be focusing on, let's see here, where's the arrows? We're going to be focusing on the measurement piece and continuing some of the dialogue that Wendy just mentioned relative to measurement. So last month we introduced the notion that on the portal now, data are available on the various measures that all of you have put in on your change plans. This diagram that's on the portal is what we call small multiples. It's a technique to show multiple measures in a single snapshot. It hopefully gives you much more of a balanced view of the measures as you walk in. It's really critical as leaders that you be aware of what are the measures that are now in the change plan. Some of you were those that directly put them in yourselves, so you're very tuned into them. In other cases, there may have been other people in the organization. But one of the questions is, how are you educating the broader audience, your other team members and leadership, others at a managerial level about these measures, and how to use the measures in the organization? And you'll find that there'll be lots of challenges that in an initiative such as this, it's a really large scale with so many different things that you have in your change plan. Early on, there's probably a tendency to put things in and just kind of say, well, let's measure this, and we'll do this, and we'll do that. And now that the data is coming up, it's like, oh my gosh, how are we actually going to do this now? How are we actually going to collect these measures? How are we going to really use these measures? And it starts to create a buzz. So, be prepared for that as senior leaders and as leaders in the system and helping groups navigate this. With that, you will find that people will go through the stages of grief with the data. You know, the first stage is denial, that the data can't be right. This is just absolutely wrong. There's no way that, you know, our depression screening rate is 10% or colorectal screening rate is 5%. I mean, we're much better than that. And they may be right. In part of our role is to look at the data integrity. And we know that many organizations historically have been woefully lacking in terms of their proper coding of data that then ends up getting captured in the claims-based systems. I know I see the payers shaking their heads. And when the data finally comes out, it's a mismatch from what you know and feel in clinical practice to what the data sets say you're doing. And that's part of our role in leadership, is to clean that up, to try to figure out how can we bring greater data integrity to get over that denial stage. We don't want to give people ammunition, because they'll do their own homework. They'll start to drill down and really look at their data elements and come back and say, oh, you're wrong here. I got proof on how many have done that. Some of it is wrong charting. Where in your record system are you putting the data? And so it's not being retrieved and aggregated in the way. And so this is a very healthy part of the journey, is to use the next few months in helping with that data integrity and cleaning up the data to be able to gain that confidence. Yes? So the question is, how much of it is the lack of standardized processes? A lot. If you're able to standardize the workflow and standardize the process and be very clear on what data elements go where in the chart, what is the process for getting that, who does that data entry, and make that consistent, your data integrity increases dramatically. So part of this journey, and we've talked about process mapping was a tool early on that we've been teaching many organizations. That's where you get the process mapping. Many organizations will take the measures that they're held accountable for, externally and internally, and for each of those measures have a very clear data process map. This is where the data comes from, how we get in the system, and they standardize the workflow so that they're able to improve the measures. So you'll often find, just by working on your data integrity without doing any other improvement work, you'll often find that you'll get a bump in your performance of your measures just by cleaning up the data process in the journey. Does that help address? So you'll once you do clean it up and there is integrity, then there's the anger stage where they're going to be really mad. Well, you know, gee, well, you know, it's not my fault. And I think it's really important to remember that historically in healthcare, it's not too long ago where data were used to really beat up on care teams, especially physicians. Under the old peer review days several decades ago, data was used to look for the outlier, to punish that person, get them out of the system. They're not practicing according to proper practice. And so we've beat people up with data, and now we've come along, switched the rules of the game, and say, oh, no, data's your friend, and we're going to use this to all work together and be happy. And they're like, yeah, right. I'll see it when I believe it. So there's still a lot of fear in the environment. In many organizations, we're hammering on our teams for clinical productivity. You got to see more patients. Got to get on that treadmill. So we're using that data to negatively reinforce, and now we're coming along and saying, oh, this data is our friend. So be very cognizant of that as we move through. And then you'll see the bargaining phase. Well, they'll start to say, well, what if we only collect a subset of the data, or just the target that we're really working on? And then a little bit of depression when they realize this is reality. And that's where, as leaders, as we hit this depression stage, it's linking them to the change plans, the tools, the methods, the resources on what to do about that performance. How can we use this data to really improve? And it'll finally get to the point where there's acceptance. This journey takes months. It's not something that generally happens overnight. You have to really build that confidence in your data set as you're moving forward with the process. So I'm going to just do a quick reminder of the different types of data. This is aimed for you, to remind you on coaching your teams and your organization. Some of you could be up here preaching about data and very, very tuned into all of this. So remember, there are data for accountability. So the Healthcare Authority has a set of measures, and they have this grant that they're holding WPCC accountable to. And so those are accountability measures. Where possible, you'd like accountability measures to line and cascade all the way through the system, but that's not always the case. Sometimes an accountability measure may not be the right measure you need at the point of service to drive improvement. So be thinking through and don't just jump on the bandwagon relative to the measures. There are measures for quality control. This is an area where we have been woefully inadequate in healthcare. We tend to do improvement projects and use data to improve, but we don't necessarily put the long-term quality control at the point of service, so that you can go in and at each care process see someone who's responsible for measuring that and tracking it. So I'll give you an example. You'll get patient complaints about waiting in your clinic. Could be in an emergency room, could be in behavioral health, could be anywhere. You get all these complaints about waiting, and all of a sudden, months later, you see your CAP scores negative, and oh, we need a quality improvement project. Oh, we have a quality improvement project, and we put a team on it, and they work on trying to improve that. But we don't necessarily put in the key metrics at the point of service that allow you to drive that indicator, that quality control. So cycle time in the clinic. If waiting is an issue, how are we measuring cycle time? And doing that at the clinic level, where they're own that, where they're responsible for it. You could roll that measure up, but the most important thing is those people that real time are working on cycle time, there are things they can do in the middle of a clinic a day to adjust things, to adjust cycle time if they're paying attention to it. But if they're not measuring it, then they're not going to manage it. So be thinking, remember quality control, and as you do various improvement projects throughout the course of the next few years, always have in your mind in leadership, what's the quality control mechanism that's going to stay in place, that's delegated down to the point of service for those that are running that process, and is in place long term. We're ensuring that reliable integrity of that system. For those of you in the hospital arena, Joint Commission, and for those that are Joint Commission accredited, a big focus on high reliability organizations. That's all about the quality control piece. It's really about building that quality control and reliable systems. There's quality improvement measures, and some of those measures tied to individual PDSA cycles. They could be very short term around a PDSA cycle, or they could be longer term based on the project, but remembering that the quality improvement measures may be different than some of these other measures in place. And then there are quality planning measures. There may be measures that you use to design as part of your quality planning system. And I'll show you an example of that in a second. The types of measures, keep in mind that there are process measures such as cycle time. There are outcome measures, so hemoglobin A1C levels for patients would be an outcome measure. There could be structural measures, which could be a policy. That you need to have a policy in place for a particular thing, or a process map in place for a particular thing. And then there can be milestone measures. We're going to make sure that we have a certain thing by X date, and once we achieve that, then we're going to get accredited by PCMH by January 30th. By NCQA. That's a milestone, right? That's a particular date and time that you're trying to reach, and that's just a measure of progress. Those are different types of measures. We also like to see, where possible, balancing measures. So a lot of organizations will go through some tough times and put a lot of emphasis on cost control and the finances, to the point where they start cutting into the meat and the bone, and you see turnover going up and you see patient satisfaction going down. So you'd like to have some of those balancing measures in the organization that you are able to see the whole picture. That's why those small multiples can be very valuable. You can see a balancing measure at the same time you're working on something else to make sure things aren't getting out of whack, and keeping that in mind. So be thinking about things as you're working with a team and they say, oh, we'd like to collect something on this. Is there a balancing measure that we can make sure that we're not doing something that is putting things out of whack? And then lastly, there's the concept of leading and lagging indicators. So lagging indicator is something that may take some time before you see the indicator change. So for those of you that are doing CAPS, the patient surveys, CAPS for the patient surveys of perceived quality and access to care, you may only do that once a year. You do it every 6 months. So if you're making a change, you might not see a change for 6 months to a year. Whereas a leading indicator is something you might see this month. You could see on a regular basis. So if you say, let's work on overall improving the quality of life for people with depression. Any of you are working on depression, if you have an overall aggregate indicator, you might not see that aggregate indicator change for a while. But if your screening rate's really low, then maybe screening is your leading indicator. Number of people screened. on a regular basis. And as you get more people screened, then you can move up to the next step on what's another indicator that'll help us see that all of this work we're doing is actually translating into improvement. So be thinking about leading and lagging indicators. Data, in the end, needs to be visualized. So we showed those run charts in the small multiples. On the left-hand screen is something called a radar chart. I bring this up because CMS is increasingly using the radar charts for some of their projects from an accountability perspective to see progress towards goal. So in a radar chart, that outer, it could be the outer rim or it could be the inner rim, depending how you set it up. But the outer rim in this case would be the goal. And so you see that there on this graph, there are 6 indicators. You don't even need to know what the indicators are. You can just visually see where the line is. If it's towards the center, that's 0 progress to goal, and towards the outside is 100% achievement of goal. So by looking at a set of goals, you can take a quick snapshot and see how is this particular entity or organization moving towards the goals. Now, what would be the downside of a radar chart like that? Any downside? This is the participation portion of the program. What's the downside of a radar chart like that? Any hypotheses? It's pretty. Lots of different colors.
One would be potentially, they appear to be valued equally.
So there's no weighting of the values. It just shows you progress to goal, and it's a point in time. So last month you might have actually had a higher performance, and this month you're lower, right? And so you're not really seeing the trend. Is the trend going in any particular direction? That's why we want to use something on the right, which is what's known as a run chart. All of you are familiar, I think, with run charts. You'll see this one is a run chart. This is actually a run chart from work we did at Hopkins years ago. And this is an annotated run chart where you see the different PDSA cycles that they tested and how it correlated with some change in the data over time. So this is called an annotated run chart. So this is great for quality improvement and for learning in an organization. If you have teams working on a project and they're making changes, as a leader, ask them, what changes are you making and how does it connect to your data? Where are you seeing the data start to move as part of your overall effort? Early on, I showed this graph. This is an adaptation of Duran's trilogy in quality. And you'll see on the left-hand side, it says quality planning. This is where we have data for quality planning. Ideally, you'd like to get feedback from your customers. Could be the payers, could be your patients and families, could be your employees, whoever you identify as your customers, and finding out what's the most important thing to them, what attribute is most important thing to them, and translate that into a key quality characteristic, KQC. Payers, in many ways, have already defined that through their HEDIS measures. They're being held accountable by CMS on a certain set of HEDIS measures, and they're transcending that on to all of you in the form of accountability in terms of measures. So that can be predefined. In other areas, you have to do a little work and gather that information and come up with something that is a way to measure how are you doing in terms of progress on meeting your customers' needs and expectations. So I'll get back to my issue of patients. If you have low patients' CAP scores, and you start to talk to the patients and do focus groups or informally talking to them, say, you know, what really impresses you most or is the most important thing? They may say ER, time to triage in the ER. And you could talk to the patients and say, well, what would be a reasonable time? If that's the most important thing, and you're coming to our organization and it's in our ER, how quickly you get triaged, then we can measure that, and that becomes our indicator. And let's say that your patients say 10 minutes is the average amount that we find would be acceptable. I want to be triaged within 10 minutes of getting there. Okay, well, we can measure that, and we can start to track it. And then we can put quality control. How are we doing? What % of our patients are getting in and triaged within 10 minutes? Well, you may find out that 90% of the time you don't do it within 10 minutes. So 90% of the time you're failing your customer, you're failing your patient. And that gives you some insight. Well, maybe we need to change that. So I've seen emergency rooms that triage before they register the patient. I'll have someone immediately do a quick triage and get to the patient and say, okay, you're stable. We're going to now get you registered and into the system. And I'm going to have Molly or John here help you with that registration. Because they recognize that's the most important thing for the patient. They wouldn't have changed their system unless they measured to see what % of the time they were not in compliance. So that's a quality planning measure put into a quality control measure. And then you can say, well, what can we do to change it? That's where your change packages get into. The change packages are the ideas, the concepts with some evidence base that they can help change the system. Now, one of the things to be looking for, common cause versus special cause variation. All of you probably have been through the quality training to some degree about common cause and special cause. So common cause variation is based on the design of the system, and how all of the variables come to play on a daily basis, and it's inherent in every event. Every process has common cause variation. Special cause variation is usually due to something outside of the process itself that's influencing the system. And it's something that often generates an immediate reaction from the organization. A board member complains, or you have a sentinel event. And all of a sudden we're jumping in, and the way we go about changing things is we try to change the system when often the event is outside of the system itself. And what we end up doing is tampering. We end up messing up the system. Yet we spend relatively little time on the common cause variation. We're constantly fighting fires on that special cause. So one of the lessons is the more you can understand the variation and start to park those things. So let me give you an example of getting a patient complaint that goes to a board member. Mrs. Jones was in your facility and got ranch dressing instead of olive and vinegar dressing on November 9th last year. What are you going to do about it? And all of a sudden, we're pulling in the food service manager or the catering people and, having these lengthy discussions and ready to change the process when that's just a special one-of event that is outside of the norm system. 99.99% of the time, you get it right. You don't need to be changing your whole system then. Unfortunately, we in leadership, I've done it in my role in leadership, others, we are constantly tampering, not understand these special causes versus these common causes. So be thinking about that as people are coming to you with a request to make changes to your systems. What is it in response to? Is it in response to a common cause that's going to help everything? Or is it due to a special cause? And maybe we need to really understand it a little bit more as we move forward. So we want to track the data over time and see the trends where possible. We want to understand those special causes and those common causes. There are run chart rules, and part of what we're doing is building capacity with your team. So this is happening in the QI affinity group that we're hosting. This is part of the QI training that we're doing. It's how to look at the run charts and understand the rules. There are handouts available and information. The special cause rules, those are the translation of those rules to understand special cause. Now, when you make changes, when you're doing PDSA cycles on a process, you're introducing special cause. That's a good special cause. You're trying to improve the system, right? What you don't want are the random special causes. So you want to be able to study the system, intervene, and then see if your process is having an impact. So let's translate theory into practice. These are needle sticks in a hospital per 1,000 patient days over a multi-year period. Do you see any special cause in there? Any special cause? See that no explanation for that peak? July of '87? All right. So this organization was a major HIV/AIDS center, and needle sticks of employees were a huge issue, huge issue. Walking down the hallway one day, there's a nurse crying in the hallway. I stopped this nurse and said, "Jerry, what's wrong?" "I can't take it. I'm on 5 needle stick committees." I said, 5 needle sticks? What do you mean? You came from a 5th meeting in 5 months in a row? No, I'm on 5 different committees. So the organization's response was not to study the data, never trended the data over time. Every month they had a chart of needle sticks, and they had 5 different committees working on this process. So has anybody looked at the data over time? And so you looked at the data over time, you see that over time there's all this random cause variation. None of those committees have been doing anything for 2 or 3 years in a row, no impact. Yet in July of 87, boom, this spike. What would have caused that spike in July of 87? Any guess? More testing? Yeah, absolutely. The CDC put out a national announcement that you need to do more routine screening and testing, and all of a sudden that there's a lot of needle sticks that are happening. You need to do sentinel reporting of needle sticks, and all these needle sticks that weren't being reported suddenly spike up. This is called the Hawthorne effect. Now, spiked up all of a sudden because an email went out to everybody, and then went right back to its normal variation. Right? So leadership, we want to understand all that craziness. We want to get in there and say, wow, what are we learning from this? How do we avoid those special spikes that are just tampering? And let's really work on controlling that data. So here's a case study of starting to break down data so that it's manageable. And I think one of the things you'll hear from the staff is this is just overwhelming. You're asking me to go out and affect these people's lives, and there's too many of them. Their lives are so complicated, it's just impossible to manage all of this. So we want to be able to make it much more manageable as we move forward. So this is a case study that we worked with a few years back as part of a national program from ONC, the Office of the National Coordinator for HIT. And in this program, they were trying to support the national goal of reducing heart disease, okay? That had been translated to Million Hearts campaign that many of you have participated in over the last few years. That Million Hearts campaign had part of their funding went to the ONC Beacon communities. There were, I think, 19 communities around the country that were funded to integrate technology and use it to drive improvement across the community. And so they said, okay, let's take 6 organizations out of that pilot. Let's get them to work on reducing heart disease. And what could they do? Well, they could work on improving LDL control. And let's do it over a very short period of time, 16 weeks. It's not take a year or 2 years. Let's do it over a short period of time. So when you hear us talk about sprints as a learning model, this is a type of sprint. Do it over a short period of time, pull us some activity, see what you can do. One organization said, okay, I'll work on that for 16 weeks. We can do that. We'll put a team on it. We have to meet weekly and really drive improvement into daily work. So they began working on it, and then they started looking at their data. They came up with their change package, or their theory of change, the ability to break problems down into their sub-processes. That we've realized we can't tackle the whole elephant, so let's look at sub-processes. That if we make overarching system changes, it would likely affect all of the data elements. Data is going to be critical to driving the improvement, and anybody can improve. So they started segmenting their data. Okay, so LDL control, number of patients that have diabetes, that have their lipids under control, and are on a statin, one of the key indicators. Let's take a look at that, and then let's look at our data. So the first thing they did is, out of all the patients we have, how many have diabetes? So that's a subset, be anywhere from 6 to 20 to 30%. So out of that 30% of people, how many were really at risk? Diabetes is a much smaller number. Now you're getting into a couple hundred. And out of those, how many have not been in for screening? The only issue is they haven't come into the clinic because they haven't been in for screening. Lo and behold, found a large bucket of patients just haven't come in because they feel well, they're okay, but they haven't had their annual screen. So that's something we can do. We can manage that. We can go out there and bring those patients in and drive improvement. So each of these represent a different decision tree of what can we do, break down the data further and further and further. And when it gets down to the bottom, there's a bucket there for patients that are just not in control, that are very brittle, difficult diabetics. And it turned out in these organizations, a very small number. Those ones had to really be micromanaged in terms of their medication control. But most of the rest of the stuff was about our processes. It's about how are we collecting the data and where were we putting it that is missing in the chart. It was about patients who haven't been into the clinic since the last data point and needed to come back in for a rescreening. Found out through this process that patients were being called in and being screened and said, okay, we need to get a lab value. but you need to go across the street to get your blood tested, and then the results will be sent back to us. Patients walked out the door and went right home because of the design of their system. So when they moved the lab collection to the point of service, their rates improved dramatically. So the point of this whole piece here is by taking a really large and unmanageable number of patients and saying, let's really understand it and start to segment the data. Let's start to break it down into those manageable pieces that we can work on. Then let's just see how we can do that. At a clinic level, what that means is let's not work on the whole population. What about the patients coming in this week? Let's look at Monday, how many of our patients are coming in, how many would be at risk, and for those patients, let's make sure we get them, get their data, get their labs, and if they need to be on a med, let's get them on a med and let them not slip through our cracks because of our processes. That led to dramatic improvements. And so you see over time, the number of the patients that had not been screened or not in control, these are small numbers, manageable by one panel of patients, but able to improve it over time. So all of this is about being clear on your measures. What are you measuring? Helping the staff understand the measures. If there's pushback on the data integrity, saying, that's great, maybe the data is wrong. Let's go in and look at it. And is it a coding issue? Is it a data entry issue? We're putting data in the wrong place in your record. Let's help them understand. Don't immediately push back. Guide them through the journey. Once you get that data integrity, then help them move up to the higher levels of what can we do to trend the data, understand it, and then use it to improve. Let's bring that back to the work here that you're going to be doing over the next few months. You may remember we had a dialogue. You may remember we had a dialogue about what condition might we work on as a group. And we talked about asthma, and the data didn't really support asthma. And what came back from all of you is that there are opportunities in depression, and most of the organizations are working on depression, and a lot of the organizations are working on diabetes care, and that might lend themselves to a collaborative effort across the WPCC over the next few months. So we're heading towards the fall, and this is the data from the, Caroline, this is from the Healthcare Authority data, is that correct? So this is the Healthcare Authority data, and I know this is relatively small, but if you look to the right far-hand column, you'll see that there are, some of those are very small numbers. A population of 2 across the WPCC, if you changed, that would improve you and move you to a different quartile in your overall data. Well, if you're getting reimbursed based on your performance and improvement, then trying to move those small numbers is not a gargantuan challenge. It just means some collaboration and figure out. That might be one organization being able to move the measure for the whole group. So we need to really understand what are those opportunities and why. And if we could really start to play with the dials together, we could move all those indicators up and really show some dramatic progress as a group. What we're proposing is that in the fall, what we'd like to do is start to work on 2 conditions as we move into the population level work. If we could work on depression and diabetes as a group and leverage the collective resources of the organizations, but also of your community resources. There are community-based organizations that are also working on diabetes, also working on depression. So how can we engage some of them? Some of the work on opioid management, for example, might have a crossover with depression and managing the underlying depression that's leading to the substance abuse. So those entities that are out in the community, how can we leverage all of that to really drive improvement across the environment? These are the common measures around depression, or these are the overall common measures that people are most collecting in the collaborative that Wendy showed earlier. So if you look at all the change plans, you'll see that almost everybody is doing depression screen and follow-up as a measure. You'll notice diabetes is not on there, interestingly enough. Yet that was the highest one, and most of you said, if we're going to work on a clinical condition, that one resonates the most with us in terms of our effort. And I know for the FQHCs that that's a core measure that they're working on for HRSA anyway. So what we want to do, and we're not going to resolve this today, but hopefully have a little bit of dialogue, we'd like to see if there's one or 2 measures in diabetes management that we could all agree on as a common measure across the board, that we could track as a WPCC, as we move into the fall October meeting, what we'd like to do is some homework between now and then to see what data are available in the environment, what data we might have available from the payers, from the healthcare authority, from any sources, similar to what we tried to do with asthma, and see what that tells us about the prevalence of diabetes in the region. And then as you look at your change plans, start to align the work as we do the population level work in the land, and we get together face to face, we're going to be focusing on content to share with you on how to improve the health of the population. And what we would like to do is use depression management and diabetes as the case studies, that it's relevant to what you're working on as entities, and then move that forward. So we'll be asking you to be thinking about what diabetes measures are most relevant to you. What are the ones that you think are being most pertinent as we move forward? And we'll have some dialogue about this at the next meeting and the following meeting. There are diabetes measures, and then you already have some depression measures, depression screening and follow-up, and then mental health service penetration for depression are two measures you're already collecting now. So that's something that's a lot more commonality around that, but we can, at least the depression screening measure is one that most of you that are working on this seem to be collecting, and we can help resonate on that. So I'm going to open up for dialogue here in a second. We're going to be continuing from a learning perspective, working on the team-based care land that most of the organizations are participating one way or another. As I said, we have 125 to 130 people on the webcast, so it's a lot of engagement on that. We're going to be doing a webcast on access in September. The focus of that is going to be really looking at what are the levers you can change as an organization to influence access, and some examples of how to do that. And then as we move into the October meeting and future webcasts and calls that we have, we'll be continuing to have access as a track that we'll be working on. Recognize that many of you have already worked on access. Others are just beginning and want to start working on access. Some of you have real lessons from your work on access that hopefully we can tease out and identify some of the exemplars and share across the environment. We'll be working on finalizing measures around diabetes care and depression, engaging all of you over the next couple of months so that you're in agreement with those measures, so that as we go into that fall face-to-face meeting, we'll have some data and information to be able to share with you, and then start to see how we can move those dials over the ensuing months. So let me stop there and see what questions you have, and then let's talk about your thoughts on some common measures of the ability to work together on depression and diabetes. So any questions to begin with? Any of that make sense? Any questions about your role in terms of supporting or helping accelerate it with the teams, either on team-based care or relative to the measures, your change packages?
The timeline for finalizing the measures is sometime between October.
Between now and October, yeah. We'll be working with you so that as we go in there, we'll all be clear. So the teams that are participating, we're going to say, here are the measures and why, and that there's been a consensus that your leadership's bought into them. It's not some wacky thing that we're imposing on you, but that the leadership really thinks these are the important things, and that you're going to be supported as you move forward in helping accelerate that. Hopefully this aligns with your aims. This is what you told us were the most important things to work on for your own projects, whether it's for your physicians or clinicians that are working on their own personal improvement projects, for their recertification, or for your external accountability, whether that's to HRSA or to payers or to others, that this aligns with that work and help accelerate, certainly in alignment with what the WPCC had suggested early on and what the state is encouraging to do, so that ideally this will cascade all the way down, and we'll be able to really show how we can move the needle on a couple of these pieces. Other questions?
Roger, can I just say that diabetes and depression was chosen by this group on that learning activity survey we put out in March. And just to note that we are one of the top performing ACHs in diabetes, but that is still something you guys wanted to work on because you're working on it internally.
Any other questions? And Wendy, I'll turn it back over to you.
Thanks, Roger. All right, we have about 10 minutes left. Let's go for a quick round robin.